So welcome everybody. So my name is Professor Ian Hall. I'm a chest physician based in Nottingham, and I'm the director of our Biomedical Research Centre. And I've also got sort of interested through a number of reasons, actually partly through discussions with NIHR, but also discussions at a local level as to how we might be able to facilitate research within the ICSs. And so what I want to share with you today is a little bit of background for those of you who aren't completely familiar with how NIHR operates, as to the infrastructure which that provides, and the opportunities around working with the ICS. But I think there are two things I particularly want to highlight at the beginning. So the first is that in the discussions I've had, and in fact, I was delivering a similar talk at the NHS Confederation meeting in Liverpool last week. It was quite interesting to note that the different ICSs, I think, are at very different stages around the country, and have got different capabilities in terms of delivering the research agenda. I've heard an awful lot of ambition. What I haven't seen as of yet is much actual examples of things on the ground happening rather than plans for things to happen. So I think a key thing will be moving beyond the sort of the ambition to actually into the delivery bit, and taking that to its extreme. I think that the thing which came out most of the discussion, which Ali Austin hosted at the Confederation meeting, is the implementation bit. So what we can do is we can undoubtedly identify better ways to deliver healthcare based upon good research, but actually getting that into practice to make a difference in terms of the healthcare pathways, both regionally and nationally, is really quite challenging. And although we have things like the Academic Health Science Networks, which I'm sure we'll hear a bit about later on, and also the Accelerated Access Collaborative, I think that there is a real problem in terms of the implementation of things that we know will improve care for patients. And essentially it comes down to funding issues. So I'll park that issue there for now, but we might come back to it a little bit later. So this, I guess, is my starting point for any discussion on this topic, which is why is it worth doing clinical research in the NHS? We've got enough challenges, as we all know, managing the front door of our hospitals or managing workloads in primary care. But it's very clear that we know that treatments we've got aren't good enough for all our patients, so we need to develop new treatments, and we need to or better use existing treatments. We need to identify different insights into disease risk to help better plan healthcare, and a lot of that, particularly in the ICS space, I think is around prevention, but it's also about having better models of delivery, particularly to the hard to reach population groups, as we've already heard. But two other things which I think are forgotten to a larger extent are that if you participate in clinical research, you have better patient outcomes. And we see this very clearly in the cancer space, where about 50% of patients enter into clinical trials, and those which are in clinical trials have better health outcomes than those who aren't. And ultimately, the aim of the National Institute for Health and Care Research is to improve both the health and the wealth of the nation. So there's another bit here about economic growth, which is often, I think, forgotten. So a number of reasons why we need to support research in the NHS. And I guess you can't really give any talk about the value of research without giving a practical example around COVID. So this is just our own experience. So back in January 2020, it became clear that there was this new organism, SARS-CoV-2, producing disease in China. We actually had some pretty close links with China because we'd had some visits from a chest physician and a radiologist. In fact, the person pictured on here, Dr. Ryan, came to spend 6 months with us, and they very kindly sent over some CT scans before we'd seen any cases in the UK of patients with COVID, and I've just shown them at the bottom there with this nasty bilateral pneumonia. But the point I want to make with this slide is that we went from only finding out about this disease in February 2020, first cases, lockdown in March 2020, to the first delivered clinical trial with a treatment which saved many lives, both in the UK and internationally, i.e. dexamethasone, within a space of less than 6 months. And so it is absolutely clear that if the system works together to make sure that we get as many patients as possible into key clinical trials, and that if the bureaucracy around that in terms of regulatory approvals, access to data, etc., is facilitated, we can make a massive difference very rapidly. And I guess that the key message for me around this is that I am concerned that we are slipping back a little bit into pre-pandemic mode, and we're losing some of those gains in the ability to move rapidly and strategically that we gained in the early stages of the pandemic. And as many people on this call will know, some of the stuff around data has been challenging, but hopefully the Goldacre report and things will help us in that space a bit. So I guess most of you will know, but just again to rehearse, the National Institute for Health Research, or as it's now the National Institute for Health and Care Research, is the major funder for research involving patients. It's got a budget of about 1.2 billion a year, and together with UKRI, particularly the Medical Research Council, funds the vast majority of publicly funded research. There's obviously a significant amount from the charity sector as well. And I think as a centre, what you need to really undertake all of the aspects of clinical research are you need to have the expertise and the infrastructure. And some of this doesn't apply to the ICSs, but some of it undoubtedly applies to the academic centres. So, you know, here in Nottingham, when I look at our biomedical research centre, it's essential that we have strong underpinning science and informatics. We have excellent inpatient and outpatient clinical translational research facilities. Maria's already mentioned our ambitions to move with a mobile research unit. You need to have research equipment such as scanners, which are dedicated for research use rather than just for patient care. Otherwise, it proves very difficult to access them. You need all the regulatory support and the clinical trials advisory support in place. But the two bits where I think is absolutely important that we work closely with the ICS, the last two bullet points on this slide. So one needs to have access to large relevant patient populations, and you need to have willingness to collaborate between the basic scientists, those who are making the early experimental medicine advances, and the clinicians across the healthcare system in order to maximize our ability to roll those advances out. And this creates some challenges. So the stated ambition, I think, of NIHR and certainly our as a teaching hospital trust ambition is to integrate research into normal practice to ensure that everyone has the opportunity to participate in clinical research studies. So you'd think it'd be fairly easy to find out whether or not we have equitable access to clinical research studies across the populations, and actually I'm finding it extremely difficult. So there are no data held that I'm aware of that can tell you exactly where all your research participants come from. So those data would be available, for example, for portfolio studies through the CRNs, but they're not routinely collected, and because of GDPR issues, are not passed on to other parties. So we don't actually know whether or not research is integrated across all the populations, at least in our patch. Others may have managed to get around this problem, but I think it's still a challenge. We need to make sure there's an attractive environment to support clinical research, and that's not just for public funded, but also for industry funded and studies. And certainly there's major political worry about the move of the large industry, large pharma companies out of the UK, and so that sort of falls into the sort of health and the wealth aspects of the NIHR mission. I've already mentioned the need to maintain the efficiency gains seen for COVID research, for non-COVID research. And then there's been a recent refresh of the Best Research for Best Health strategies NIHR produced, which in particular highlights the challenges to the UK population of long-term conditions, multimorbidity. And we've already heard, and I'm sure it's going to be a theme all the way through today's discussions, about the need to engage with the hard to reach parts of the population. So I work in a biomedical research centre. I run a research group which does molecular genetics. Why is that in any way relevant to the integrated care systems? Well, integrated care systems have got research in their remit, and of course they're ideally placed to link between local authorities, the primary and the secondary care sector, to help with the access to the populations of patients that we need to deliver research. And there will be benefits from that, because not only will we deliver better research, but those that the steps you need to put in place to do that for research will be exactly the same as the ones that you need to deliver it for care pathways as well. There's a clear remit to address inequality and access to healthcare, and that's, I think, equally important for research. And the integrated care systems are sat on some really potentially rich sources of data, which not only help inform research, but also give rise to new ideas for research projects, as I'll talk about in a minute. So I thought it might be a good idea to give you an example of some of the work that we started to do with the ICS here in Nottingham and Nottinghamshire. And as a respiratory physician, I thought I'd talk a little bit about asthma. I heard COPD mentioned earlier, and I could have given exactly the same sort of set of information about COPD because we've done some work in that area, but I'm going to talk about asthma. So we know how to treat asthma. There's a stepwise progression of treatment as recommended in the British Thoracic Society, sign, NICE guidance, etc. I'm not going to run through it, but it's on there. Except just to mention that the 7th step on there, we've got a bunch of biologics which are now available for the management of difficult asthma. And we manage those through regional multidisciplinary team, MDT meetings. But at the moment, we have very little knowledge as to whether or not there's equity in access to those, and I'll come back to that point in a few minutes. So this is some work that we ran in Nottinghamshire. I'm very grateful to Sergio Papalaterra from the Nottinghamshire ICS who provided some of the data I'm going to show you now. And this was generated using a local data tool called eHealthScope. And the first thing we did, as you would expect, is to look to see what the prevalence of asthma is in the region. And this is, I think, quite interesting because actually we used here a definition which was the presence within a GP care record of a presence of an asthma diagnosis, but also of an asthma treatment prescription in the previous 12 months. And it's color coded with the darker the color you can see on there being that the higher the percentage of asthma diagnoses. And perhaps somewhat surprisingly, the first thing that strikes you is that the areas with the lowest recorded prevalence of asthma and patients on treatment are actually in some of the inner city areas. So particularly Nottingham, in the areas around the university will stand out, but actually bits of Mansfield and Newark have got the same issues. Now clearly this could be just due to natural variation in the prevalence of asthma, but I think we can get some further information to address that question. So is this being driven by a difference in the rates of diagnosis? Is that driven by deprivation, for example? Is it driven by different rates in different ethnic groups? Is it perhaps being driven by student populations, particularly in Nottingham, given that the areas with the lowest recorded prevalence are the predominantly student areas, or is it just bad data quality? So we've looked at all of these things in turn. I'm just going to run you through some slides and give you the headline messages. So this is GP recorded prevalence of asthma using the same definition, but in this time with quintiles of deprivation scores using the index of multiple deprivation. And what you can see that there's maybe a small effect, particularly in, I guess, in South Notts, but across all of them, the differences in recorded rates are pretty small. So it doesn't look as if deprivation is really driving those differences that we originally saw, which I would have guessed if you'd have asked me before we started looking at the data might well be an issue. What about ethnicity? So ethnicity data are quite interesting. In all of the parts of the Nottingham and Nottinghamshire healthcare system, the likelihood of having an asthma diagnosis is much higher if you are in the white group in the population, and much lower if you're in other ethnic groups, and particularly in the black, actually, particularly in the Asian, populations. So there are two explanations for those data. The first is that asthma rates could genuinely be lower in some of those ethnic groups, or alternatively, they could be under accessing healthcare or being underdiagnosed. There are quite reasonable data on ethnicity and asthma, and what most data show that once people have moved to the UK and have been here for a couple of generations, rates of asthma prevalence are very similar to the white population. So I think it's unlikely that this is driven by true differences in the different ethnic groups, and it must therefore be due to access to healthcare systems. So obviously an issue there which requires further study. And then to try and get at this issue as to whether or not the asthma prevalence is just due to low rates by chance in some areas, we've looked at asthma admission rates. So you'll remember that Nottingham City had the lowest recorded prevalence of asthma, but it has the highest recorded number of emergency admissions to hospital in the last 12 months with asthma as a primary diagnosis, with actually 0.5%. So one in 200 asthmatic patients in Nottingham City have been in hospital in the last year with an acute attack. So that doesn't suggest that there's just much lower rates of asthma. It suggests, if anything, there's under treatment of asthma patients in those areas with the lowest recorded prevalence using the GP data. And so looking at the student population, I think is kind of interesting. So if you then go to the records and say, well, what about the actual prevalence and then treatment? What you see is that recorded asthma diagnoses is actually similar in the Nottingham City areas, boxed in red in this left-hand side of the slide, but actually the treatment is much lower in those groups. So this obviously generates a hypothesis, which is that for whatever reason, the predominantly student populations around Nottingham University are not accessing treatment from their GPs, which they're registered with here. And given that they're ending up in hospital, it's quite likely, I suspect, they're undertreated. And these may well be students who are accessing some treatment from their GPs where their home originally were, but they're not accessing through here, and they're falling between the cracks in the system, or like one of my daughters used to do, trying to buy stuff over the internet to sort of get around the issue of accessing healthcare. So there's obviously a bit of work to do, I think. An interesting research question about what it is that's preventing, driving up hospital admissions, but reducing treatment rates in this particular group of subjects. So I'll just share that with an example of how the data not only can give you information about healthcare pathways, but can suggest examples of research projects which could come from those. So the implications of this, I think, are that asthma admissions are commoner in areas where recorded prevalence is lower. Improved access to healthcare would potentially improve outcomes. Differences in asthma prevalence are clearly present by ethnicity. Are these due to underdiagnosis or different rates? A bit more work's needed around that. I mentioned at the beginning the issue about uptake for severe patients of biologics. Well, we haven't started to do this yet, but one obvious thing to do is to try and find out where those patients who are accessing the biologics are coming from. Are they representative of the group of patients as a whole, or are they coming from particular pockets of where there's greater knowledge about the uptake, about use of these drugs? And what we don't have, as I've already said, is we don't have data on research participation at the moment, because we do a lot of research studies on patients with asthma, and I just do not know where our patients are coming from who are accessing at a local level. So what else are we doing in Nottinghamshire with the Biomedical Research Centre? So we're doing some further analyses, deeper dive into asthma, I've already mentioned. We've got a similar programme of work ongoing around COPD. And the other bit of work we've done, which hasn't involved the ICS directly, but has got implications for the ICS, has been around the use of the community monoclonal antibody units for access for people who are eligible for monoclonals for COVID-19, and I'm going to share a bit of data with you about that in a second. We've also trying to get around this issue of moving from having good ideas to actually doing things, and so we run an annual innovation scheme through the Biomedical Research Centre where we pump prime research projects, and this year we prioritised projects which were joint with the integrated care system. And I'm pleased to say, because that's obviously quite a big divide moving from what's essentially an experimental medicine-driven BRC out into the broader landscape of ICSs. But we have actually received a couple of really nice projects which start to address issues which are relevant to both of us. So those will kick off imminently. And I think the other bit, as I think Maria mentioned right at the beginning, is that we have done our best to engage with the ICS, and actually the ICS has done its best to engage with us, I think it's fair to say as well, in order to make sure that we have coherent plans for research delivery, but also that we integrate those with healthcare system delivery plans at a regional level. So here are some data which have not been published yet. So I'm showing you stuff which is unpublished. It's been out under review for a while. But actually, I talked about this very briefly at the NHS Confederation and was immediately accosted by someone who has to give a report on this very issue about access to monoclonals for patients with COVID-19 this week. So I've shared the data with them. So I thought I could share it with you. So as I guess most people on this call will know, the regional CMDUs were set up late last year to facilitate access to monoclonal antibodies and antiviral treatment for those considered at high risk from COVID in the community. And I'm not going to go through all the indications, but the at-risk groups include those who got cancers of one sort or another, particularly people on chemotherapy, hematological malignancies, patients who are immunosuppressed because they've got transplants, for example, and a whole group of people who are on immune suppressive drugs, often with rheumatological or other inflammatory conditions. And of course, if you go back to the early days of the pandemic, it was being reported to me that fatality rates amongst these individuals, if they caught COVID, could be as high as 10% of the population group. So the CMDUs were set up to try and facilitate access of these patients to drugs at an early stage. But of course, it's really important to know whether or not that system works and what the outcomes of those interventions are. And at the moment, as far as I'm aware, there are no published real-world outcome data. So we did a service evaluation of the Nottingham CMDU, looking at 28-day outcomes in patients referred during January and February of this year. And some quite interesting messages come out of it, which I thought I might share just as sort of a way of indicating how working regionally may actually be lead to, give us a way to deal with some of the challenges. So these are the data from our CMDU. There were 1,820 individuals who were thought potentially to be who might benefit from treatment. In fact, it turned out that when you went through all of the criteria, many of them actually weren't suitable, despite being listed as potentially suitable, and actually only 604 were suitable for further assessment. And of those, 254 were treated and 336 were not treated. Mostly that was because people had resolved or resolving symptoms, but 70 individuals who would have been eligible for treatment actually declined treatment. And that's in a way kind of useful because we sort of got a bit of a control group there. I mean, of the 254 who were treated, 80 got molnupiravir, 169 got sotrovimab, and 5 got Paxlovid, because the numbers are small. I've not dealt with those in any analysis. So what actually happened? So of those individuals, 28-day hospital admissions ranged from 6.5% in the sotrovimab group down to 2.5% in the molnupiravir group. But actually, most of those people were getting admitted to hospital for reasons which were nothing to do with COVID, because of their, often because of their underlying conditions. And in fact, the COVID-related hospital attendance rate, as you can see, there were 2 in the sotrovimab group, 1 in the molnupiravir group, and 3 in the declined treatment group, and actually 7 in the resolving symptoms group who had a COVID-related hospital admission. And this involved us trawling not only through our own hospital, but also Kingsmill Hospital records as well, because North Nottinghamshire is served by there. But I guess the key take-home message is that the mortality rates from this in these groups were extremely low, and the only person who died actually received molnupiravir, and because of COVID, and 2 of the people who actually didn't receive any treatment and got resolving symptoms actually died, but nobody in the decline treatment or the satrifimab group died. So, given that the original molnupiravir study suggested something like a 10% rate of severe disease, why do we see these differences? So the simple answer is, I don't know for certain, but I think there are 2 things which might explain the fact that healthcare utilization for this group seems to be low. The first is that we were dealing almost entirely with the Omicron variant, which tends to cause milder disease. But the other thing is that the big clinical studies, for example, with molnupiravir, were done in an unvaccinated population, whereas almost all of our individuals had received a vaccination. And although we haven't got antibody data on everybody, and there's a range of responses from a sort of low antibody response to essentially a fairly normal looking antibody response, it is clear, I think, that because people were vaccinated in the main, then their healthcare outcomes, even in this group, seem to be better than was seen in the clinical trials. We tried to look at deprivation to see whether or not there were regional differences in terms of access to treatment, and slightly confusing here, I'm showing you mean IMDs rather than quintiles. A little bit unclear, but just at least a hint that those individuals who declined treatment were so the median IMD you can see there in that group is 20.9, whereas in the treatment groups it was 16 in both groups. So a hint that maybe people declining treatment were coming from more deprived areas. And so in summary, I think this work, it's only done in one centre, and obviously ideally you'd want to link it together with data from other centres. But what they show, I think, are that the referral pathways are actually really rather inefficient. Only 1 in 3 of the people referred in are potentially suitable for treatment, and only 1 in 7 actually got treated. There's a suggestion, which needs some further work, to evaluate of inequity of access based on those median deprivation scores I showed you. The key message is that very few COVID-19 related hospitalizations were seen, even in those declining treatment. And so given the cost and the effort required to set these clinics up, there's obviously a question as to whether or not these are cost effective and whether it's worth them continuing, particularly given the challenges over coming up with the right monoclonals for whatever variant is circulating at any given point in time. So I think these are the sorts of local and regional data which throw up research questions, can also be used to help address health inequalities and plan system care. So I've had about my time, so I'm just going to wrap up. So my summary will be that we have extensive infrastructure in the Midlands to help support translational research. I mean, obviously I'm based in Nottingham, which has got a biomedical research centre, but there's one in Leicester, there's one in Birmingham as well. And as Alex mentioned briefly earlier, what we've tried to do is to bring together all the NIHR infrastructure in the Midlands through the Midlands Health Alliance in order to integrate the support mechanisms and ensure that we can work across the region where necessary. And there are plenty of examples of projects which are going on across the BRCs or across other parts of the NIHR infrastructure. Just to reinforce that engagement in research improves outcomes for patients and helps with planning healthcare interventions. And I think by integrating research activity into the ICS programs, we can improve healthcare outcomes whilst also supporting research. And I've given you some early indications of how the sorts of things which might help to deliver that. So I'm going to stop at that point. A huge thank you, as I said, to colleagues in the ICS who shared some data with us. Also to Amanda Goodwin and Jonathan Thompson, who did a lot of the work around the CMDU work here, and of course all my colleagues in the Biomedical Research Centre who've helped support all the work that's been going on regionally through the BRC. So I will stop screen sharing there and hand you back to Alex. And Alex, I'm very happy to answer any questions if anybody has anything they wish to bring up.
Yeah, thanks for your presentation there. Really appreciate it. Has anyone got any questions? Yes, Salma? And please, everyone, introduce themselves. That'd be great.
Thanks, Patrick. I'm Salma, and I'm the Programme Director for Health Inequalities at Birmingham Solihull ICS. Just a quick one. I'm just trying to understand how this connects with, for example, the West Birmingham and Black Country Academy, because we're all talking about having some kind of intelligence hub. Nobody's going to disagree that we need good data being collected and we need it shared, but there seems to be a bit of a grey area around the mechanics of that, and how we can align what is already there and know what isn't there, and be able to build something which is meaningful to us in the NHS, but our local authority colleagues, and actually to the wider community as well.
Yeah, so I can't answer specifically about your academy, but I think the point is that there is very little federation of resources across different parts of the system, and so I showed you the data generated regionally with sort of the Health Scope tool, but I think that we've had some real problems in having a coherent data offer, and you'll be aware of all of the fuss about making the opt-out for GP data across the system, which has caused us major problems. I mentioned the Goldacre report, and it's all about better integration of the data resources that we have available to inform both research and healthcare delivery. And I think unless we can really push that forward, we're going to be stuck where we are at the moment, which is sort of regional or sort of local sharing of data, and just a few big data sets like the HES data and so on, which people can access at a national level. So I think we've really got to fix that, because at the moment, as you sort of highlight, it's rather fragmented.
Sorry, can I just have a quick follow-up? Who funds this? So where does this sit? Is it with universities? Is it with enterprise? Is it LEPs? Is it NHS? So just curious as to know.
You're asking generically, are you? Yeah. So there are good sources of funding. Health Data Research UK, for example, fund an awful lot of activity, but at a local level, it's being funded through a whole range of different sources. And of course, one of the challenges is that there is no uniform, apart from the HES data, sort of secondary care data set. We do have pretty good GP primary care based data sets, but because of the funding model whereby they sit within the providers, the electronic healthcare systems that are used in primary care, then the only way of getting hold of those data is to pay a license to CPRD and organisations like that to access sort of large chunks of data. So I think the funding is an issue, because what we obviously need, in my view anyhow, is to have essentially open access for approved use of all of those different healthcare data sources.
Okay, thanks. We've got Mick next.
Hi, thanks. My name's Mick Steiner. I'm a respiratory physician in Leicester. I'm also just been appointed to the medical directorate to the ICS in Leicestershire, so I'm starting to take an interest in all of this. So Ian, thanks very much for an excellent talk. Stimulated a couple of thoughts. One of the things about the ICS is that it should transform how people move between different parts of the healthcare system. And I think one of the things we're going to really need to do, and potentially it's an early win, is risk stratify our populations, particularly those with long-term conditions where they do navigate to different parts of the system. And your example of asthma, where a small subset of people will need biologics, requires us to identify who those people are and try and proactively make sure that they get seen in the right health setting, particularly if we want to access difficult to reach sectors of the population. And that would apply to other respiratory diseases, chronic renal disease, and so on. So I think finding a way of doing that, and we've done risk stratification before, but it's often about outcomes rather than about access to treatments, and those things are very different. The risk stratification for treatment is modifiable risk, not absolute risk. Yeah. So I think that's an early win. And then the second comment, I guess, was a bit of a challenge about your comment about the CMDUs, which in a way is a sort of rapid implementation of a risk stratification approach. You identify a needy population. But you commented that it was relatively inefficient, and I wouldn't have interpreted it in that way, because if you look at lung cancer pathways, for example, you want to be referring more people and actually have cancer. Otherwise, in your denominator, which you can't measure, there'll be lots of people who would have been eligible who didn't receive it. So I guess I was going to ask for your comment on that, and I guess that has to inform our thinking about how these things work. Otherwise, we might be unnecessarily negative about how the process actually works.
Yeah, thanks. Great to hear you've been appointed, Mick, to the ICS. So so I take your point actually about the you know, what's the optimal efficiency in terms of a pathway. I do know there's an awful lot of work for people trawling through all of the potentially eligible people who turned out not to be. So so maybe a 1 in 3 sort of hit rate isn't that unreasonable. You might well be right. And as you say, if you're looking at something like cancer screening, you'd accept that quite happily, wouldn't you? So maybe you're right. Maybe it isn't as inefficient as I perhaps implied, but it certainly was expensive and time consuming to set up and run. And so that's a value judgment, I suppose, as to where you draw that. Going back to the other comment you made about equity of access. So, you know, so obviously in Leicester, you've got fantastic work in looking at some of the ethnic minority, well, in some places, parts of Leicester, not even minority populations, are they? So, so I think that, and what everybody tells me, and it's certainly our experience locally where the ethnic minority populations are smaller in Nottingham, is that you can't use standard approaches. You have to go in through different routes, for example, through faith groups, community centres or whatever, because otherwise you don't get any traction. So I think, you know, the model of delivery is going to vary from centre to centre depending on what the particular challenges are. But we have to move away from the, oh, you know, we've identified you as high risk, come to the hospital to an outpatient appointment sort of approach. And so I think it's getting the message out there through non-conventional routes. And secondly, then it's going to be about moving the care into those communities rather than doing it in the big white centres, and that's going to, you know, sort of the shining sort of hospitals, whatever. But that's going to require a range of approaches, and you know, so the idea behind the sort of mobile unit we put together is obviously predominantly around research, but it can also be used for sort of healthcare delivery. Although how well it will, how it's a fairly large lorry, and I'm slightly anxious about how it's going to make its way around all the winding side streets of inner city Nottingham. So we'll see how that goes.
Great, thanks for that. We've got Tim, and then if no other questions, we're going to move on to as part of our agenda. So Tim.
Hi, Tim Robinson. I'm the Commercial Director at East Midlands AHSN. You'll hear more from me later on. Ian, it wasn't a question, it was just more of an observation to make that asthma biologics is an area of therapy that the AHSN network has been supporting nationally. It was selected through, a group of those therapies was selected through the Accelerated Access Collaborative Rapid Uptake product, so AAC RUPS as we call them for short, rolls off the tongue. So there might be some learning from the HSN network around some of those areas that you flagged that are worth sharing. So it'd be good to try and catch up outside of this forum and see if there's anything that we can kind of bring together on that. Yeah,
I'd be very, very happy to do that. Sounds good. And as I said right at the very beginning, a lot of discussion at the NHS Confederation about this is the implementation bit is tricky, isn't it? Because there isn't really a funding source in there to make you rapidly roll things out. It's dependent upon, you know, cases of need, etc. rather. So that's the bit I worry most. We can have fantastic pathways, but actually, if there's no resource to bring them out more widely, it's going to be quite tricky, I think.
Yeah, I think it is one of the challenges, especially when some of the previous schemes did come with a certain amount of pump prime funding to help to get over that first phase of work so that you could then generate the evidence to build your business case to actually. So yeah. I think there are some challenges in that. But be interested to have a conversation around that particular area and see if there's anything we can share.
Okay, so that's just a quick flurry of hands. So we've got J.R. Raffenfan and then David.
It's Giri, Patrick.
Oh,
Thanks
Giri,
very much.
I'm seeing first now. Okay.
No, that's fine. So, Giri, I'm from the Office of Health Improvement and Disparities in the Midlands, and jointly with Chris, I also chair the regional Health Inequalities Group. So, the point about implementation that Ian made is absolutely right. And of course, currently, what the implementation system focuses on is for stuff to be published on electronic platforms, so the NIHR stuff, the NICE stuff, and all of those sorts of things. But there's little work then subsequently taking place in terms of, well, how does that then get into practice? And really, that bit of it, as Ian said, is challenging, but I don't really see a lot of work that's actually taking place. So the question to NIHR colleagues is therefore, if it's not getting into practice, then shouldn't NIHR be doing something about it, is my question, really. Shouldn't they be doing something much more active and trying to research more active methods of getting those sorts of evidence into clinical practice? Yeah, because the history behind a lot of this is pretty old, really. I mean, probably some of you are much too young to remember Tudor Hart from the 50s and 60s very well. And then, of course, in the 80s, we had active discrimination against women and cardiac surgery with Hemingway and so on. In the 90s, we had older people discriminated against, coronary care units not allowed to get in there, and so on and so forth. So there's a fair bit in here. So coming back to the implementation bit, I think that there is a challenge for NIHR.
Yeah, so
what is it? Go on then, Ian.
So I completely agree with almost everything you say, except perhaps the NIHR bit. So I mean, NIHR really delivers infrastructure and research. And once you get to the stage where it's essentially a business case to make it routine practice, I'm not sure that's NIHR's remit, and they certainly don't have the funding to do it. And we've had, I mean, our experience, for example, we've had a very successful project looking at picking up early liver disease, as you may know, the Scarred Liver Project, etc. And actually fighting that through the different bits of the implementation pathway, despite support from the Academic Health Science Network and, being highlighted by the King's Fund and things like that, has been really quite challenging. And it's still not widely taken up, despite us being able to demonstrate it's cost effective. But I don't think NIHR can fund that. So there has to be a different funding mechanism, I think.
Okay, great. We've got David and then Chris and Tim.
Yeah, so just backing what Ian has said, in that when we've got new research coming in and an agreement about implementation, the lack of visibility previously at system level was quite marked, actually, in many systems. And I certainly for Nottingham, I'm proposing a way that we can bring that through. So the sort of the operational improvements, or the improvements that we'd expect to see with other programs of work, from a research and innovation perspective, we've got the same sort of profile. So I'm looking forward to linking in with you, Ian, and Tim, and to say, how are we going to take that forward? I recently spoke with the medical directors in the Nottingham area, and they were really keen that the visibility and the implementation of these things we've been described earlier is much more focused, and the boards are much more aware of them. So we're looking forward to keeping in touch to walk through how we can make that work in Nottinghamshire.
Yep. Yeah, looking forward to working with you, Dave, because I know you've been fairly recently appointed, haven't you? So great to see that.
Okay, I'll bring Chris. I know, Tim, you're going to be speaking very shortly, so can you hold back? That's okay. Chris?
Yeah, so thank you, everybody. I've been listening quite carefully, and I suppose one of the key messages I've picked up from what I've heard so far is this issue, this tension between moving from a business case to implementation. And I think it's worth just noting that actually this isn't a new problem for us at all. I mean, if you look at the health inequalities agenda, we had the Black Report 1979, we had HSN in the late 90s, we've had Marmot in 2010 onwards, all producing reports saying this is what we need to do and this is how we need to improve the world. But we haven't moved it from a sort of outline business case to full implementation. So I do wonder whether there is something we should be researching here, which is actually, how do you take something from that initial business case idea, concept,
to the point where actually people will invest time, effort and resources to implement a key piece of work. A lot of the time, we know what needs to happen. The issue is we're struggling to get it to happen. So, maybe it's a slightly different take on what research we should be looking at, but I think it is worth potentially exploring as we go forward.
Yeah, I think that's a perennial question for every of us to think about, everyone. So can you hold that one for later? Maybe how we can, that's part of going to be our challenge as ICSs. We're going to get some fantastic research work, some fantastic innovation, and then we have to look at the coffers and the time and the resources. So this is going to be a challenge for all of us. At this stage, I want to thank you very much, Ian, for your great presentation.